The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome to Knowledgeable Provider. I'm your host, Jody Marks. I'm going to do something a little different this week and make an episode specifically in response to an episode of another podcast. That would be the Annals on Call podcast, which is associated with the Annals of Internal Medicine, which is the journal of the American College of Physicians. Their latest episode that came out on May 19th is an interview with the author of an article from the Annals journal, pretty much talking about how terrible mid-level providers are, nurse practitioners and physician assistants, or maybe that's becoming physician associates. I'm not 100% sure on that. PAs. The author's name is Dr. Kristen Giordano. Her article was written in response to another article published by the Association of American Medical Colleges. They had the audacities to suggest that the giant shortage of primary care doctors in the United States could be made up for with mid-level providers, nurse practitioners, and PAs. So I want to go through and respond to several specific points that they make in this podcast interview. But before I do that, I want to back up and kind of set the scene here. If you just listen to this as a one-off thing without knowing the broader context, it might not make as much sense. If you weren't aware, there's a lot of hatred for mid-level providers out there among physicians, and I feel like it's more directed toward nurse practitioners than it is toward PAs. So I'm mostly only going to speak about nurse practitioners since I am one, of course. I discovered Reddit right about the time I started working as an NP, and there are a lot of very cool medical subreddits. There are subreddits for nurse practitioners, but also for different types of physicians, residents, medical students, etc. So I jumped into all of those. I'm like, heck yeah, I want to learn from these discussions that they're having on here. And I very quickly had to get back out of those subreddits because I realized that a lot of what gets talked about on there is how much they all hate nurse practitioners. There's even a subreddit dedicated to only discussing hatred of nurse practitioners called Noctor, N-O-C-T-O-R, as in not a doctor. For my own mental health, I had to very quickly get away from those subreddits and those conversations because it kind of made me question my life for a little while. So I think I can summarize the thinking and the position. Apologies if any of this is inaccurate, but it seems that a lot of doctors or a lot of physician organizations have the idea that the powers that be, the powers that run medicine, that being administrators and insurance companies, people who handle the money side of medicine, are all out to replace physicians with mid-level providers because it's so much cheaper. And of course, a lot of physicians feel like mid-levels, nurse practitioners especially, are not nearly as qualified to take care of patients as physicians are. So before I go any further, I just want to make it clear that I really don't disagree with any of that so much. I think anybody who's been in clinical medicine for any significant length of time, at least in the United States, has to develop some hatred for administration and insurance companies because they just make our lives so difficult and they make things difficult for our patients, and they're really good at turning us and the patients against each other when everything that's wrong is really their fault. And there are a lot of other systemic problems with the medical system that end up kind of looking like our fault, but really aren't. Anyway, that's a whole other discussion. But I 100% could see how the powers that be would push for mid-level providers above physicians because we're cheaper. I mean, depending on the specialty, you could have 2 or 3 or 4 or 5 of someone like me for the cost of one physician. So from a financial standpoint, on the surface at least, yeah, it does make sense. And I would not doubt for a second that there is a push to make care more cost-effective by paying us, providers, less. And regarding the training aspect, nobody in their right mind should ever suggest that nurse practitioner training and physician training are equivalent. I'm in the position of having actually attended medical school. I did that for 2.5 years before I dropped out and then eventually went on and became a nurse practitioner later on. So I have some idea of what physician training is like, at least the initial part of it. And I know exactly what nurse practitioner training is like, all of it. And they're just not even in the same solar system. I mean, medical school is notoriously intense. It's a full-time thing. in my case, I spent almost every day of my life during that 2.5 years with my face stuck in a textbook, sitting on my butt, studying 6, 8, 10, 12 hours a day, every day, compared to nurse practitioner training, which I was able to complete while I was working a full-time job and a part-time job. I mean, I learned stuff, I got trained, and of course, by the time I did that, I had the benefit of having gone through 2.5 years of medical school, but still, like, clearly not the same. And then when you throw in residency, my goodness, a board-certified physician not only went through medical school, but then worked in their specialty for however many years, 3 years, 5 years, 8, 10 years, if you're a neurosurgeon or something, before they were ever turned loose to work on their own. So there's literally no question that physician training is far superior to nurse practitioner training. So my impression is that primarily what these physician groups object to is not necessarily the existence of nurse practitioners, but the idea of independent practice for nurse practitioners. And I think in roughly half the states in the United States, nurse practitioners are allowed to just do their own thing without being associated with a physician. They can go hang their shingle out and run their own practice. Alabama, where I live, is not one of those states. We do not have independent practice for nurse practitioners. And I also want to be clear that I am not a proponent of independent practice for nurse practitioners either. Of course, that's just based on my own personal experience with the training and knowledge and whatnot. I don't know how things are in other states and other situations. But just based solely on my experience, I would not have been comfortable practicing independently right out of school. I think the training is just not good enough. You don't get that experience primarily of going through residency, I think, that a physician gets. And Dr. Giordano talks a lot about that during this podcast interview. And she's right. I think my first few years in practice kind of amounted to residency. She and Dr. Centaur, who is the host of the Annals on Call podcast, talk a lot in the interview about how when you're in residency, not only are you being directly supervised by an attending physician, but you're getting constant feedback from your attending physicians about, well, here's what you could have done better, or here's where you messed up. You're not just working with no supervision. So in my case, again, I'm not suggesting this was equivalent to residency, but my first few years in practice were somewhat like that, in that, of course, I was in the same location with my collaborating physician. Initially, I was only seeing patients that were his patients. I didn't have any of my own until we ended up taking over another practice a few years later. And not only did I send every single note that I wrote to him, but every day at the end of the day, we would verbally discuss every single patient that I saw that day, whether that was in person or by phone. We had some pretty interesting situations where the doctor I work with would be off on vacation, so he'd be on a mountaintop in Peru somewhere or whatever, trying to hear about these patients that I'd seen that day in Decatur. But we did it every single day. We did it. I would go through and verbally present each patient to him, and we'd talk about what I did and what the plan was and whatever. And we did that for, I want to say 3 years, maybe. I think after about a year, he kind of said, if you're comfortable, we don't have to do this anymore. And I kind of said, well, I kind of like it, actually. I like getting the reinforcement and feedback and making sure that I'm not screwing up here. And we eventually did stop doing that. The way we function now is I still send him every single note. So he still sees every single note that I write and signs off on them. And now I'm not only seeing his patients, but I have patients that are only mine that I only see. But he's still right across the hall. We have parallel hallways. And if something comes up that I have a question about, I just run over there and grab him. I say, hey, what do you think about this? Or, hey, come see this patient. Or, hey, come look at this and help me because I don't know what to do here. And I think really that's how it should be. So I'm not really in disagreement with the big overarching things that they're talking about on this podcast episode. When I listened to it initially, I started to not listen to it at all because I knew it was going to piss me off. But then I decided to listen and I was like, okay, I'm going to listen to this very impartially and I'm going to try not to take it personally. I'm going to try to listen to what they're saying. And of course, it instantly made me mad. But in thinking about it, I think it's the tone that made me mad more than what they're actually saying. I don't completely agree with everything they're saying, but the tone is just so, I'm going to say, disrespectful, unprofessional, condescending. You would kind of expect somebody to throw in a statement like, oh, I've worked with some really good NPs and PAs through the years and blah, blah, blah. But here's basically the tone. I'm going to play you a little clip that gives you an example of the tone of this whole thing.
I didn't realize that AAMC, it says that we can solve the primary care crisis with physicians, assistants, and nurse practitioners. And it made me nauseous.
Now, I should also say before we go further that during my little stint in medical school, I had the opportunity to meet Dr. Centaur and learn from him in person. I have nothing but respect for him. He's obviously very smart. He's a good teacher. As far as I could tell, he's a good doctor. He was always nice to me personally. So I don't mean to throw any shade at all at Dr. Centaur personally. And this is Dr. Centaur, by the way, of the Centaur criteria, the clinical criteria that you can use to rule out streptococcal pharyngitis. Pretty cool. But that tone is just the general vibe that I got from listening to this whole thing. And I guess at the end of the day, that's really what aggravated me and it's made me decide that I need to respond to this. We got one little bone thrown to us by Dr. Giordano. So here's that clip.
And it isn't to say that PAs and NPs shouldn't have a role in the team. They absolutely should have a role. And we can talk about that on another day about what that role should be, but certainly not as the primary individual taking care of the patients.
I wish she had gone into what it is she thinks that I'm qualified to do. Like maybe I could, I don't know, take blood pressures on her patients or tell them where to park outside the clinic. I don't know. I would love to know what Dr. Giordano thinks that my role ought to be in the healthcare system. Dr. Giordano herself was a PA before she went back and became a physician. So I guess that's why she feels more qualified to speak about this particular subject. I'll be honest and say that I didn't like her very much after listening to this episode. I went and found an episode of another podcast where she was interviewed for back in 2021. That podcast is called Patients at Risk, which is a whole podcast dedicated to talking about how terrible mid-level providers are. And I actually liked her better after I listened to that episode. One thing she mentioned back then that she did not say on this Annals podcast is that part of the reason she decided to become a PA was that a PA took care of her mother and ostensibly did a good job. So I guess she's cut that little positive piece out of her spiel. She worked in hepatology as a PA and then went back to medical school and became a nephrologist. So never has worked in primary care as far as I can tell. I think they could have been a little more upfront, transparent about how biased she is against mid-levels. It says this in the article she wrote. They did not mention it in the podcast, but she is a board member of this organization called Physicians for Patient Protection, whose sole mission in life is to prevent mid-levels from practicing independently. And by the way, I did not read the article she wrote. Of course, you can't read it for free. You have to pay $37 if you want to read this article. And I'm not giving her $37, so I'm just going by what she said on this podcast. But she is the author of the article. So she had quite a lot to say about how mid-level training compares to physician training. Here's what she had to say about PA training.
Physician assistants have anywhere from 24 to 27 months of training. That includes half or so quote unquote book learning in the classroom and the other half doing rotations in a variety of fields, similar to medical students, surgery, OB-GYN, family practice, pediatrics, psych. And I say 24 to 27 months because they typically don't have summers off. It's a continuous program.
She had quite a bit more to say about nurse practitioner training. Here we go.
Nurse practitioners tend to do anywhere from 12 to 24 month program, usually master's to doctorate training.
Accurate. I did a 24-month program for my master's degree. I didn't get the summers off either.
Their training is not on the focus of medicine per se. It's a lot of statistics, navigating advocacy, educating other nurses, some theory, but they're not doing typically anatomy and physiology.
This is quite an exaggeration. I spent the vast majority of my time in nurse practitioner school learning about medicine with my face stuck in a medical textbook, just like when I was in medical school. It is true that we had to take classes that were not specifically about clinical medicine. Those classes were shared with other graduate nursing students. Remember, not everyone who goes to graduate school in nursing is becoming a nurse practitioner. Some of those people are on tracks for education, administration, non-clinical things, and we do take classes together. There was definitely a lot of what I would call fluff on my board exams. I took the ANCC board exams for family practice and adult gerontology, acute care, and I was really surprised at how much of that there was on there. I was not really prepared for all that. Evidently, I figured it all out because I passed, but fair point on that. And we know there's a bunch of fluff in nursing education at the undergraduate level, but I will point out that nurses, RNs, thinking about at least inpatient facilities, have to deal with a lot of stuff that is not about medicine that doctors never have to worry about, right? Like you as a doctor, come around, see your patient, write your orders, go away. We may not see you again until tomorrow. I, as a nurse, am stuck with that patient and that patient's family for the next 12 hours. I'm expected to know enough about the medical side of things to not only take proper care of the patient, but also be able to explain to the patient and the family what's going on, answer any questions they have, etc. I also have to know how to physically give the medications that you've ordered, right? I have to know how to open the packages and reconstitute the drips and operate the pumps and all those little details that you never have to worry about. I have to know where to get a freaking turkey sandwich for their uncle. I have to know how to put the right orders in and the right departments to call when I need help with things. When you come by and write that the patient gets discharged, somebody has to know who the right people to call are and how do we get this person into a facility and how do we get all this paid for by insurance. All that stuff's done by nurses, not to mention the whole, like, who's going to staff this unit for the next 12 hours and how are we going to properly allocate all these patients and how are we going to divide out all our tasks so we get everything done on time. None of that do physicians have to worry about. So yes, there is some fluff in nursing education, but there's also a lot of fluff in nursing work. And as far as the anatomy and physiology thing, every nursing student already took anatomy and physiology before they even become RNs. I assume maybe she's talking about gross anatomy, which, yes, we did not take gross anatomy, and I wish we did. I personally took gross anatomy in medical school, but yeah, agree. I wish that was more a part of nurse practitioner education.
They're not rotating through surgery subspecialties.
I did a trauma surgery rotation as a practitioner student.
They do about 500 minimum clinical hours. Some obviously do more. If you look at Duke, they're doing closer to 1,000 hours.
1,080 clinical hours total for the dual role program at the University of South Alabama, where I attended.
Those hours are not typically regulated like they are with medical schools. They don't have an overseeing agency verifying that they're meeting all these requirements.
Honestly, I don't know what she's talking about. I tried to Google and figure it out. I didn't find any specific agency that accredits clinical hours for medical students. My school's accredited by the Commission on Collegiate Nursing Education, as well as the Southern Association of Colleges and Schools Commissions on Colleges, the SACSCOC. Okay, don't worry, Dr. Giordano. We're Saxacock accredited. But yeah, I don't know what she's talking about there.
And again, they're not doing the subspecialty training. So they've chosen a pathway, either primary care or emergency acute care. And their hours are focused on that.
I did clinical rotations in family practice, internal medicine, ER, pediatrics. I already mentioned trauma surgery, obstetrics and gynecology, and cardiology. As far as specific certifications that nurse practitioners can obtain, we have family nurse practitioner, adult gerontology primary care nurse practitioner, adult gerontology acute care nurse practitioner, psychiatric mental health nurse practitioner, pediatric nurse practitioner, neonatal nurse practitioner, women's health nurse practitioner, emergency nurse practitioner, oncology nurse practitioner, orthopedic nurse practitioner, pulmonology nurse practitioner, cardiology nurse practitioner, and then of course you have clinical nurse specialist, CRNA, which is nurse anesthetist, and certified nurse midwife. She goes on to talk about just how terrible we are at taking care of patients in general. She cites this particular study out of somewhere in Mississippi that found that patients got much better quality care when they were only seeing an MD versus a nurse practitioner. And, okay, I'll put a link to, how about 9 studies that show that NPs have lower costs of care, higher patient satisfaction, and better outcomes. And really, none of that means anything to me. Like, if your organization hates NPs and does a study to prove that NPs suck, guess what you're going to find, right? If you're a pro-NP organization or an evil corporation who's out to get rid of doctors by showing that NPs are better, guess what your studies are going to find? I mean, these studies are biased. You can't do a double-blinded, randomized, controlled trial to see if NPs or doctors are better. And why would you? So, okay, here's your research if you want some research.
They actually found that patients who had an NP as their primary care clinician were more likely to go to the ER than someone who didn't even have access to primary care at all.
I met those patients who didn't go to the ER. When I worked on the ambulance, they're the people who dropped dead at home, and we had to go code them in their living room, and their families told us, yeah, they've been complaining of chest pain for the past 2 weeks and wouldn't go to the hospital. If they'd had an NP to tell them that having chest pain is a reason to go to the hospital, maybe they wouldn't have coded in their living room.
You can't really overstate the importance of how that impacts our patients when they're sent to an ER unnecessarily, a subspecialist unnecessarily, or unnecessary imaging.
Because no physician's ever ordered anything unnecessary, right? And who gets to say an ER visit or a referral is unnecessary? That's a very case-by-case basis.
As a nephrologist, I have seen countless patients who came to my office terrified that they were going to be on dialysis just because they were sitting in my office, when really they never needed to see me at all. And a primary care physician would have certainly been able to manage their condition. Oftentimes it was inappropriately or inaccurately interpreted test.
I'd love to hear more than one specific example of how somebody misinterpreted a patient's creatinine and GFR. That sounds like probably an exaggeration to me. I will say that I think NPs probably are more likely to send patients to nephrologists. I've seen just in my own experience, and actually even talking to people who work in the local nephrology office, I think there is a phenomenon where we NPs are a little more trigger happy than doctors to send people to nephrology once we identify chronic kidney disease. So I'll give you that one. But misinterpreting, I have a hard time believing that.
So I do think that there's a significant impact that NPs and PAs have in the primary care field that can be negative. And so we need to not make a policy broadly saying they can replace primary care physicians.
I did read the AAMC article that she's writing about. It's a very short article. I didn't quite read it the same way she did. I didn't read anything in this article that is suggesting replacing physicians with mid-level providers. They've come up with a different model of projecting that. That's really what the article is about. They're projecting a shortage of 68,000 primary care physicians by the year 2036, and they're estimating a surplus of 74,000 NPs and 13,000 PAs. What the article says is, hey, we don't have enough doctors. We have too many mid-levels. These mid-levels could fill in the gap, which seems like a pretty benign statement to me. I don't know if we're just reading the article differently or if they just saw an opportunity here to jump on this and try to prove their point about what they were already trying to prove anyway. But there's a couple places where I think she really missed the point of what this little article is saying. She goes on this weird rant about how the article's suggesting that primary care is not a specialty.
I think what was striking about this is that in saying that, they are insinuating that primary care is not a specialty on its own. I think that's something that is very important to remember, that primary care is a specialty, and then we have subspecialties outside of that. That is the same as saying general surgery isn't a specialty, and we would not ever say that. So that goes towards the respect that we should have for primary care and the expertise that our primary care physicians bring to the table.
I didn't really get that from the article, but okay.
Articles like this in particular really hurt primary care. When you say things like, quote, primary care most commonly includes treating less complex conditions in patients with few comorbidities, I wouldn't want to go into a field that's seen that way, right? You're disparaging the important work and the expertise of our primary care physicians.
Here's the full paragraph. Quote, the delivery of primary care services remains essential to a well-functioning health system, and many of these services can and will be provided by non-physicians. Research already suggests that non-physicians are increasingly delivering care to patients in ambulatory and other settings. Within primary care, this most commonly includes treating less complex conditions, parentheses, e.g., urinary tract infections, low back pain, acute respiratory infections, close parentheses, in patients with fewer comorbidities. Additionally, in many specialties and subspecialties, non-physician APCs, I think that is advanced practice clinicians, also complement physician work. This task shifting has helped increase capacity, allowing oncologists, surgeons, and other specialists to see more patients. Unquote. I don't read that as primary care means you see less complicated patients. I read that as saying mid-levels are often seeing the less complicated patients in primary care. The very next paragraph says, quote, given the ability to shift the work of primary care from physicians to APCs, it is possible to eliminate primary care shortages in the next decade, but only if that workforce is efficiently and effectively located and utilized. This requires that health professionals and health systems be able to actively triage patients to the right care providers at the right time, regardless of how or why those patients are seeking care. Due to the lack of a cohesive national system to facilitate this triage and the current inability of even large geographically dispersed health systems to efficiently assign patients to providers, this is still unlikely. Unquote. They're saying that more complex patients should see physicians, not mid-levels.
I think one of the things that proponents of increasing NPs and PAs as primary care clinicians, as the only person in primary care clinician role, says is that, well, all these NPs are practicing at primary care. In fact, the AANP says that more than 70% of them practice primary care, but when you look at the actual data, it's only about 1/3 of the graduates actually practicing on a daily basis in primary care. Most of them are still choosing subspecialties. And in one of them in Oregon, it was just 25%, and that's where they can practice independently.
Okay, so it's the same issue as physicians. We prefer to go into a subspecialty. So what do we do about it? Well, here are her proposed solutions.
I think we need to work on primary care reimbursement. It's gotten so poor that some of my colleagues haven't been able to keep their independent private practice open because they're operating in the red too often.
Is everyone as tired as I am of hearing about how poor the doctors are, how little money they're making? Give me a break. But better reimbursement for primary care? Yes, I'm with you.
I think we need more administrative support so that they're not doing a lot of the tasks that can be done by someone who's not a physician. I think we should be removing barriers to care, like prior authorization for physicians with high approval rates, and decreasing metrics that rely on patient adherence and not physician compliance with that, standard of care.
That should be pretty easy to pull off, right? We'll just get the insurance companies to change their whole way of doing things. Sounds great to me. Let's do it.
We know that physicians who do residency in one location tend to stay in that location. That happened to me. And I think it's about 70 or 80%. It's really high. So I think increasing our rural primary care residencies is essential. And it's difficult because many of our rural hospitals are closing. And that's an area that patients really need to be supported by and need primary care physicians more than anywhere else because they don't have access to specialty care the way that city dwellers, so to speak, have.
Sounds great to me. I don't think anyone disagrees with any of that. I imagine the AAMC doesn't disagree with any of that. Is any of that feasible? Is that going to happen rather than letting mid-levels who are already out there taking care of patients continue to take care of patients? Here's what I think they should be saying. This is very reminiscent to me of this whole debate that has gone on and maybe still goes on, I'm not sure, in EMS world. At one point when I was a medic, there was this big uproar about whether or not paramedics should be allowed to intubate patients. If you place an endotracheal tube and miss, if it goes in the esophagus and you don't realize it, well, now you're only ventilating the stomach. I hope I said that right. I don't have any training in anatomy and physiology. Let's see. The esophagus bone's connected to the stomach bone. Yeah, okay, that sounds right. So, you might as well just hold a pillow over the patient's face and call it a day. At least if you're ventilating just with a bag valve mask or with that and a simple airway adjunct, some of the air is going to go in the lungs. And intubation is a hard thing to learn. It's kind of tricky even in the most controlled circumstances in an operating room with an anesthetized patient. Trying to do it out in the field in somebody's living room or in a car or in the back of the ambulance makes it a heck of a lot more challenging. And there's this one particular doctor, I can't remember the name, but he put out this study that showed that paramedics were killing people trying to intubate him, and he was very anti-paramedics being able to intubate. And my thing was always, why are you not screaming for better training for paramedics rather than just dogging us and saying that we suck and can't do this? That's kind of how I feel about this discussion as well. Little details notwithstanding, again, I really don't disagree with a whole lot of what this lady is saying and what a whole lot of these doctors out here are saying about the situation. What I don't get is why are they not saying, hey, why don't we have better education for these mid-level providers? Why aren't you pushing for, hey, nurse practitioner school should be 4 years like medical school. Nurse practitioner school should be a full-time program like medical school. Nurse practitioners should do residency like physicians. If you're worried that they're trying to push you all aside because you make too much money, well, why aren't you advocating for more money for nurse practitioners so we're closer in pay? There's none of that. You could even be advocating for some sort of different pathway for NPs and PAs to go back to medical school and become physicians. If there was some sort of expedited route to take for that, don't you think most of us would take it? Patients ask me all the time, when are you going to go back and become a doctor? As if it's just about showing up and filling out some forms and taking a couple of classes. And these are not people who know that I actually did go to part of medical school. And I usually say something like, well, if you can talk somebody into supporting me for 10 years and giving me $250,000 to pay for it, I'd be glad to go back and become a doctor. What I really want to say is, when are you going to become a doctor? Because it's almost the same path. This all just strikes me as gatekeeping, And here's another angle. For me as a gay man, it's pretty hard not to hear all this in the same kind of rhetoric-y, persecutory way that people have talked about gay rights. It's kind of the same thing with NPs, like, we're here, baby. We're here and we're peers, like it or not. We're out there taking care of patients. So instead of just dogging us, how about trying to help us out? And regarding this specific article that we're talking about, it's co-written by a physician. It's published by the association that's in charge of the medical schools. How can that organization be anti-physician? This whole thing strikes me as just a very biased misrepresentation of a pretty benign article. So there you go. That's what I have to say about this podcast episode. If you think I'm way off, if you have anything to add, please get in touch. Special thanks to our Patreon supporters. Thanks to all of you for listening. Have a great week, and I'll talk to you later. All right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.